He was 16 or 17 years old at the time. And the wreck was bad enough that it essentially blew the bottom out of his vehicle. Like the floor was just gone.
Wow.
The guys on the first arriving fire apparatus, I want to say they got him out in like 7 or 8 minutes. It was super quick. By the time I showed up, they had just transitioned him into the ambulance and he was in a bad way. And I was like, hey, I'd love to stay and do this while we're not moving down the road, but like we got to go. There's more going on here than I can fix by myself. And we took off and we went in such a way that we ended up leaving the new guy just standing on the scene like, well, where am I supposed to go?
Where'd everybody go?
Yeah, but by all measures, I want to say his ISS was within the range, his injury severity score, the trauma data people do. By all measures, I think he should have been dead.
Welcome to In Service, the EMS Podcast, where frontline experience meets leadership insight. Hosted by Jason Falvey, a seasoned paramedic and EMS leader with over 30 years in the field. This show brings you conversations with people shaping emergency medical services today. From street-level medics to innovators on the bleeding edge of EMS, we dive into real stories, leadership strategies, and what it takes to build high-performing teams in high-stakes environments. Let's get in service.
We copy you down, Eagle.
Today's guests come from a busy seaside vacation destination in the Carolinas, where the population can explode during peak season and the call volume never really slows down. Michael Henry and Eric Falvey bring a great mix of experience, leadership, and real frontline perspective. Michael, with nearly 2 decades in EMS, has grown from field provider into a clinical and operational leader, helping push programs like blood administration and RSI while keeping a strong focus on how providers think and perform. Eric represents the next generation, working in a high-volume system, stepping up early in his career, and taking ownership of critical patient care when it matters most. Together, they show where EMS is heading: more capability, more responsibility, and more need for strong decision-making in the field. This isn't just about having advanced tools like blood, ultrasound, or RSI. It's about knowing when and how to use them under pressure. Mike brings the big picture view, how to build systems, train people, and make it all work. Eric brings the street-level view, what it actually looks like in the back of an ambulance. And that combination gives you a clear look at a progressive EMS system, high stakes, fast decisions, and the need to get it right when it counts. Let's get into it. All right. Hey, welcome. Good morning, guys.
Good
How
morning.
are you?
Good.
Mike,
Good.
Eric?
Good morning.
Morning. So I'm very excited about today's episode because we're going to be talking a little bit about RSI, blood products, ultrasound, and really where the future of EMS is going. And I think that's a really big topic that we can dig into here. And also really the unique environment that you guys work in here based on your seasonal population and the challenges that brings. So before we dig into all that, let's talk about a little bit where you're from. Mike, where'd you grow up?
So I grew up just north of Boston, little town of Revere. So I was right near the city, close enough to
Yeah.
be part of it, but far enough away to escape it when we needed to. Boston boy, born and raised.
Yeah. I'm not picking up on the accent.
Yeah, no, I got made fun of a lot when I moved down here. Had to hide it.
Quickly.
Did you
change.
park your car at Harvard?
I did park my car, and now if you give me a couple beers, you put me around my friends, it comes right back.
Oh, yeah, it does. It never goes away. How about you, Eric?
Also from Massachusetts, but I really lived here in Myrtle Beach since I was 10. So I'm from here. I'm a local here to Myrtle Beach now,
Yeah. You've lost it too.
for sure.
Local as they come.
Yeah. So what inspired you to get into EMS, Mike?
So I had a weird path. I actually grew up wanting to pursue a career in law enforcement. One of my cousins was actually a paramedic at the time, and recommended I take an EMT class my senior year of high school and just give it a shot as a job while I was in school or whatever I was going to pursue. And I worked my first shift on an ambulance and said, I'm going to be a paramedic for the rest of my life, and I never want to grow up, and I'm going to do this.
You know, a bunch of my paramedic friends were taking the police exam. I took the exam, and I went to a police academy in the early 90s, but I never worked as a police officer. It just didn't hit me. How about you, Eric? What inspired you to get into EMS?
Yeah, probably in high school. When I was in high school, I had a neighbor. He worked for the fire department. He was a volunteer for the fire department. Really got me into the fire department aspect of it. We'd be hanging out and a call would come out. We'd listen to the radio and he'd drop everything just to go. Kind of had a sense of urgency and purpose, which I thought was awesome. So I really honed in on that. And then as far as EMS, I went, as soon as I turned 18, I started volunteering, went to college, got my EMT, and that kind of translated into running the calls and seeing the calls and actually doing it, not just listening to it. And I really fell in love with both fire and EMS. And when I was working on, at the time, the busiest ambulance, I was getting kind of bored of driving these high acuity calls to the hospital and not really being able to be a player in that. I kind of just really wanted to do more. And then, of course, with you would come visit and we'd talk about EMS all the time and talk about stories and the responsibility it is to be a paramedic, and really lit the fire under me. And that's when I went to paramedic school.
Awesome. Yeah. And you've done quite well. Yeah. We're very proud of you.
Thank you.
I know Mike is, and myself.
Very proud.
So do you have any, let's start with Eric. Do you have any calls that stand out so far? And how long have you been a paramedic now?
Paramedic 8 years. I was an EMT for 5 before I went.
So 8 years, man. You've seen it, especially in this environment.
Yeah.
So what calls stand out to you?
One of the calls that really stood out to me is when I was, my first cardiac arrest that I ever ran by myself in my own ambulance. Shortly after graduating, we go there. Routine cardiac arrest. The fire department was there doing CPR. I get there and it was a VTAC arrest. So we went and defibrillated right away. Started off with medications and I was getting ready to intubate. We do everything on scene. So I was getting ready to intubate and one of the firemen said, "Hey, whoa, stop. He's moving." So he started kicking his feet and I was kind of rolling my eyes like, no. And so we stopped CPR for a second and he was in VFib. And so we said, okay, let's continue with the cardiac arrest. Let's continue CPR. And I went to go intubate and they would say, "He's moving." And I saw his arm kind of lifting up. And it was very confused, being the first cardiac arrest I've ever ran. I said, "I don't think this is how it's supposed to happen."
That's the one you want to go smooth, right?
Yeah. And luckily, our EMS captain was nearby and he came up and he came in and we were still doing CPR. He said, "Whoa, stop. He's moving." We stopped, VFib, completely flaccid once we stopped. And so we were thinking, okay, this is CPR-induced consciousness. So at that point, not having too much experience, I said, let's just start going. Let's go to the hospital. And we went to the hospital, and on the way to the hospital, he was kind of opening his eyes during compressions. But every time we'd stop for a pulse check, flaccid, not moving. So very scary for me for my first ever call. I think I handled it fairly well. He did make a full recovery out the door of the hospital. But even the hospital, when we brought him in, the doctor said, "Oh, he's moving." So we're like, "Okay, watch this." And we stopped and he was like, "Okay, all right." That doesn't happen too often. So
yeah, that is really unusual. And, your first arrest by yourself, you really just want to get through that.
Yeah.
You don't want a curveball like that happening. The guy is kicking and moving. Wow. How about you, Mike?
Yeah. Looking back at 18 years, the one that stands out the most, especially, I think just kind of shaped my career, is a really mundane one. The service I worked for when I initially started as an EMT, we did a mix of 911 and interfacility transfers. And I was an 18-year-old kid. I wanted to be on the high acuity stuff. I didn't want to be doing transfers. That's boring. This is for old guys and people who don't know better. And we went to a nursing home. We were taking a guy to a doctor's appointment, and we were checking the boxes. We were doing what we needed to do, but I wouldn't say that I had the best attitude about it that I could have. And it was a long ride. We were taking him from VA Bedford to VA Jamaica Plain in Boston. So we had a good little ride.
Oh, yeah.
And
I know the area well.
You got to kill some time on those rides. And so I was just talking to the guy, and he was a medic during D-Day on Normandy. So I got this crazy history lesson, and it kind of shaped my perspective in that you never know who somebody is or where somebody's at or what they've done or been through. So I try to keep that mindset with every interaction that I've had through the rest of my career. The calls where you get to do a bunch of procedures or medications or make a positive impact. Like you can see where you've turned the patient around. Those are fun, but those are the smaller subset of our calls.
Right.
On every call, we have the opportunity for like personal human interaction. And that really shaped sort of how I approach patients and patient care since then.
You know, you think about thousands of EMS calls you run over the years. You know, very few people have tried to kill me during those calls. This guy, half the people present are trying to kill him.
Yeah.
God almighty.
Yeah. It was.
Imagine that.
It definitely gave me perspective.
Yeah.
Just on everything. Because and the worst part about it too, and we see it now, you know, following GWAT and all that, we're dealing with strangers most of the time.
Right.
These people are caring for their friends.
Yeah.
Which is a whole different ballgame. So.
And think about the tools we have at our disposal today.
Oh, yeah.
Right? And just when I came out of medic school, it has expanded so much. But back then, in what, 45?
Yeah.
God.
Yep. They're looking at, you know, here's a morphine syringe and a tourniquet.
Yeah, and pressure bandages.
Hope for the best.
Yeah.
Yeah.
And we still do that stuff today.
Yeah.
Right?
Tried and true.
So you guys work in a vacation destination.
We do.
Community.
We do.
Right? Pretty large. It's about 1,100 square miles.
Yeah.
Encompassing many fairly big cities too.
Yeah, definitely big cities, you know, geared towards tourism and vacations and being on the beach and that sort of thing.
Yeah. And you guys have festivals here a couple times a year, and that swells the population quite a bit. And your county now has about 400,000 residents, but that can swell to 2 million during those summer months, right?
Between regular vacation travel, summer vacation, people out with their families, festivals, you know, holiday weekends, concerts, all this other stuff. We definitely get up there. We're definitely full. No room at the end.
Yeah, and so there are some operational challenges with such a seasonal population swings. And you still have the routine calls coming in every day that you're running. But when you see a population swell that big, that's got to present some massive operational challenges.
Yeah. We're a combination agency we do it all. All of our guys are trained to that sort of equivalence level where Eric could be on an ambulance tomorrow and then on a fire truck the next day doing both. You know, so we deploy very fire-based, which has its ups and downs. You know, the more static deployment model, but being on 24-hour shifts and being with your crew. We have crews that just run all day, especially in those peak times. Yeah.
Wow. That's crazy.
Yeah.
That's a big area.
Huge.
And let's talk a little bit about, you guys have bike festivals that come to town here, right? Couple a year in May, is it?
Yep. Month of May, we have back-to-back consecutive bike festivals.
And one of them caters to more of an established group of older people that ride, and the other one is a younger crowd. Yeah,
we definitely see a shift in the age range of people showing up. There's always a mix, but you know, if you were to average the age out, you know, you tend to have an older crowd earlier on in the month, and then as you get closer to holiday, the Memorial Day holiday, it tends to get a little bit younger.
Sport bikes, faster moving, riskier behavior.
Definitely.
And what type of injuries are you seeing with that?
I tend to see all of it. A lot of motor vehicle accidents, fights. You know, people are down here for a celebration and to be out with their friends. So, you know, there's always the alcohol-associated injury. Or
alcohol-induced arguments.
Yeah, exactly.
Disagreements.
Motorcycles. Yeah. Doesn't work too well.
Yeah. It gets worse when the weather's bad. You know, you then take all the people who are here to be out riding their motorcycles and you push them all into their hotel rooms. The party continues and, you know, the call type changes, but the calls keep coming.
Wow.
Yeah.
Wow.
Yeah. A lot of it's trauma, but that's just as it relates to the bike festivals. You know, we still have that 400,000 plus year-round population. We have a higher average age. You know, the average age is 47, 48 years old. It's saying that we have more than our fair share of elderly over 65.
We have our hands full on an ordinary day without the influx of people. So when that influx comes, it just adds a whole variety of calls, a lot more calls. And with the bike fest, a lot of car wrecks, shootings. We do add a few extra peak load units through those times, pretty much from May to the end of summer to help cover that.
And you still have people stepping on seashells and eating shrimp when they shouldn't be.
Yep. Yeah. Yesterday was just
Allergies don't travel.
People having
with you.
babies, right?
Yeah.
yesterday was just a regular Friday. We ran just shy of 300 calls.
Wow.
Yeah. Yeah.
Calls.
We do a lot of volume.
Yeah.
A lot of volume and a lot of acuity.
You're deploying how many ambulances?
So 27, 28 ambulances, and we supplement those with, our fair share of QRVs, and we have paramedics deployed on fire apparatus. That's our minimum. During your peak times, like Eric was saying, towards the summer, we put up peak load units that run, 10 a.m. to 10 p.m. and 11 a.m. to 11 p.m. just to provide us with that additional transport capacity. Our busy sort of holiday weekends, 4th of July, Memorial Day, we'll put up more additional 3 or 4 ambulances just to cover that area. Traffic's worse. Response times are longer. Getting back from, the hospitals are full. So now we're having boarding and sitting on the wall. So just to try to keep that number down, we upstaff our units.
So how do you define the culture here?
Ooh, that's an open question. What do you think, Eric?
Yeah, well, I think it's kind of a combination of experience and expectation from the department. I think the culture is really strong. We have a good group of senior medics that set the tone day to day. I think we're pretty aggressive in a good way, treating someone before they crash, not waiting for them to crash before we treat them. And, at the same time, we get a lot of backing with our administration. I think our administration, along with our medical director, they've really made a broad scope for us. And it's not like we get to do a lot, but we're almost expected to do a lot because we have all this technology at our hands and we want to be aggressive and we want to treat. So I think the backing that we get from our leadership is really beneficial.
And you guys are a pretty forward-thinking, pretty progressive department.
Yeah.
You've got RSI, blood products, ultrasound. And if you look at blood products alone, probably less than 1% of EMS agencies in the country are running blood.
Yeah.
I don't know what the numbers are on RSI, but ultrasound's got to be even less than that.
Yeah.
Especially deployed in the field. So let's talk a little bit about blood products. And what was your decision to implement that?
So with my background, so I was in training before I came out to the field as an operations guy. That was, it's got to be over 10 years ago now. We started talking about blood back then. The people that we have within the administration, especially within like our training division, they're very, very up on the newest, latest, and greatest. It originally came up in conversations back then. Was this something we could do? But it's a challenge. It's a huge challenge.
Yeah, it's not like the administration component of it is one thing. You can train your paramedics up on warming the blood before it's given to the patient. It's really the logistical side of it.
Yes. Logistically, it's a nightmare.
God almighty, it really is. And it's expensive to do.
Yes.
Yeah. Are you carrying whole blood or component therapy?
So right now we have component therapy. You brought up the logistical challenges. So it'd be near impossible and almost unethical to rob the blood banks to put blood on every single ambulance. With 27 ambulances, that's a lot of blood. It being constantly in shortage, it would create a lot of problems to try to do it that way. So we've taken sort of the cue from other services that do it, and it's deployed on the medical officer's vehicle and the 2 safety officer vehicles. Right. They tend to be roving units. They're never QRV style vehicles that you never know where we're going to be, but we tend to show up when stuff's going on. And we're carrying component therapy.
So what were some of the operational challenges you encountered?
I think one of the big things is kind of buy-in from the medics, the street medics. It's definitely intimidating. There's a factor there that is kind of scary. It's a big responsibility. And luckily we have a lot of really good paramedics. We have a lot of a strong core that know why we have blood and want to give blood. But it is asking a lot, sometimes. I think it can be scary. So the training and getting it out there and having a lot of the senior guys spread the word on why we're doing it. That's as far as what I can talk for. I know, Mike, you probably have a different view on that.
Yeah, no, and Eric's right. It's buy-in from the field is huge. No matter what you do, if you don't have the buy-in from the people that are actually going to be the ones using it, it's not going to work. Like you said previously, covering 1,100 square miles, we have some units that are less than 10 minutes from a level 1 trauma center. We have other units that are an hour plus from their coverage area to any level trauma center.
Wow.
So it's logistically and operationally, there's challenges there. The guy who's 10 minutes out saying, well, should I try to request blood or should I just giddy up and go, versus, hey, I'm 45 minutes out from you. I'm an hour plus from the hospital. Where can we meet? Where can we have this handoff to do this? That's definitely a challenge. It's changing the mindset of the providers to, hey, let's not think about right now. Let's think about 10 minutes from now. Let's think about 20 minutes from now. Where are we going to be at? Because if their pressure's low now, it's not going to get better. We should have this conversation early and start lining it up so that we can get it as we go.
Yeah, especially if you have a trauma patient that's maybe in shock. An hour and a half is...
Yeah, no, you don't want to be with that long.
You're not going to make it. You're not going to make it.
No. We have smaller community hospitals between those areas and the trauma center. Are you better off stopping for blood and initial stabilization there, or should you push it? These are things that our providers are balancing on the fly every day.
And we talked a little bit about Bike Week earlier, and you were talking about how much it improved once they put the loop in place.
Yeah.
And how many miles is that loop?
23 miles. And once you're in it, obviously emergency vehicles can get in and out, but once you're in it, there's a lot of traffic, slow moving. It messes up the traffic pattern of the roads that aren't necessarily part of the loop. So the loop only runs from 10 p.m. to 2 a.m., kind of what law enforcement sort of found as the hot button time for stuff to start popping off. But that 4 hours, it's a long 4 hours when you're sitting in traffic.
Yeah. And are you staging units on the far end of the loop? Is that how that?
Yeah, we have during the day, a lot of our units are deployed where there's larger population centers and pockets of people. Once the loop goes in place, we usually move them to sort of access points within the loop so that they can go either direction.
Yeah. How early in the shock index are you guys deploying blood products?
So 0.9 is our cutoff. So if you have a shock index of 0.9 or greater, we don't want to wait till you hit that. They say 0.1, you have a positive shock index, but if you're hitting 0.9 and there's an indication, go for it.
Yeah. Makes perfect sense. What do you think are some of the most common mistakes providers make when recognizing hemorrhagic shock? Let's take a minute on that one, right?
It might be a little difficult to answer.
Other one.
I'm just trying to
the advantage of having a lot of questions.
Come on, Eric. You just spent 4 hours with me learning about hemodynamics the other day.
Ooh.
Yeah, I'm trying to think.
Shows how good of a teacher I am.
Yeah. No, I think you're the best.
I would probably think there are going to be providers that are just going to be hesitant to start products early.
Yeah.
Yeah. And I think that'd probably be one of the biggest mistakes is hesitation, right?
Well,
letting the patient go too far down.
Right. And we want to treat before it gets to that point. So the recognition that it's going that way, the trend, I think, is one of the harder things to get out there. Is, like he said, at 0.9, yeah, we're not seeing that 1 and above yet, but we know where it's trending. And we did a good assessment and we know what's going on. And we want to be aggressive or intentional and treat early. And I think that definitely is a hurdle we're not there yet, so let's just wait. That's not really a good thing. That's not what we want.
Yeah. The patients who are obvious, your giant puddle of blood and pale, cool diaphragmatic pressure in the 60s, no palpable distal pulses, your providers are getting those.
Yeah.
Right.
Yeah.
We're not having an issue with those ones. I don't think, and this doesn't even just necessarily relate to our agency, but I think sort of all agencies. Paramedics are very good at convincing themselves of things.
Right.
That elevated heart rate is from the anxiety from the crash. That middle of the summer, it's 110 degrees standing on the pavement. My heart rate's probably 110. Well, a lot of shape, I'll admit it.
Come on, 120.
Yeah. But I think that frequently we maybe gloss over certain symptoms or signs because we've sort of downplayed it in our head of, oh, well, it's not shock. It's 110 degrees out. Or,
right.
I think that's something that gets missed a good bit. The other thing is and we talked about it when I was teaching, the blood pressure cuff on the LifePak 15 or the LifePak 35 or cardiac monitor X, whatever you want to call it, it's a random number generator. It gets a pressure, does some calculus, and gives you two numbers. And I think that as a profession, not even just pre-hospital, but even in hospital. I work in the ER part-time. If the blood pressure doesn't fit your clinical picture, maybe try investigating it a different way. It's when I see a blood pressure of 170 over 140, I have to start asking questions.
Right.
The random number generator lied.
Let's talk a little bit about the barriers or the logistical barriers of carrying blood, right? Storage, transport, replacement, because there's a shelf life.
8 days for plasma.
Yeah.
The packed red cells have like a 60-day shelf life. We keep ours till 14 days before they expire, and then we swap them out with a local hospital. That probably closer to three weeks or a month that they're with us, but they're always going back in time to be utilized at the facility. We don't exchange our plasma. We buy our own plasma, but for the red cells, which are such a limited resource, those are getting exchanged.
How about storage? Because the compliance on that's got to be tremendous.
Yeah. So we have them deployed in a smaller group of people. We don't have 15 units of blood running around. So we use I think it's the Delta cooler. They have these super ice packs that get deep frozen. They have to thaw for 15 minutes before we get them in, or the blood gets too cold. And those will last us. We change them in the morning before shift, and we're good to go.
Yeah, military grade. Right?
Yeah. I'd love one for the beach in the summer. It's the best cooler I've ever used.
Yeah.
And we have thermometers that are monitoring it very aggressively.
Yeah.
So any change that it records in the temperature is sent to everybody's phones,
Yep.
and it notifies them saying, hey, just so you know, it went up 1/8 of a degree, and that way they can really monitor. And
when my counterpart changes it out in the morning, he changes the ice packs in the morning before I come in, my phone will alert that it was outside of temperature for 47 seconds while he was switching the ice packs. So it's tightly controlled.
Are you finding you using it more in trauma or medical?
It's
I would think trauma, but
the vast majority that we've used has been in trauma, and I don't have the exact number on number of administrations. It's not an astounding or staggering number, but we're definitely using it more on trauma. I know I ran a call where we used it on a patient with varices, had variceal bleeding.
Right.
It definitely has a lot of uses, especially we have, like we talked about, we have that older population who's at risk for GI bleeding and stuff like that. So it's definitely going to get used more going forward, I think, as opposed to less.
You guys deploy rapid sequence intubation in the field.
We do.
And so let's talk a little bit about that.
Yeah. We got 8 RSI paramedics sprinkled amongst all ranks. Your rank doesn't matter. Your assignment doesn't matter. You are just a resource out there, and wherever you happen to be, you can go forth with that.
It's competency-based.
100% competency-based. We have, I think our minimum is 3 or 5 years of experience before you can even test to be part of the program. We keep it small. We have a lot of really good providers who are aggressive, skilled, knowledgeable. Guys like Eric who maintain their calm in the chaos, and they bring a great resource when it's necessary. It's a great procedure when you need it. I remember the days before RSI was a thing, because working in Massachusetts as a paramedic, RSI is super limited in the state of Massachusetts at the time, at least when I worked back there. I don't know if it's opened up more now.
Yeah, you had to be under a special project waiver just to get that.
Yeah, there were 3 or 4 agencies in the entire state that did it.
And it was limited really to helicopter.
Yep, helicopters. I think Worcester did it.
Yeah.
Boston EMS maybe, and that was.
Do you mean Worcester?
Worcester. So it was super limited, and I remember even shorter transports from the outlying cities to downtown Boston. When you have that patient who's trismic and clenched, and you're trying to use a BVM and hoping for the best. So it's definitely a great procedure when you need it. It helps patients, helps providers.
And it's such a low frequency event. How often are you using it here?
We actually looked at that the other day. We do it about 100 times a year.
Yeah.
Wow.
Yeah, we do anywhere from 100 to 110 a year, which is kind of the reason we keep the provider group small.
So if you look at that, the average provider is probably doing it twice a year.
Mike does about 50 of
Yeah. That's your thing, huh?
Yeah. Well, it's the nature of my job. As the roving operations clinical supervisor guy, I'm going to the high acuity calls anyway. And like I said, it doesn't matter where you're assigned. If Eric's moved or something for a day or whatever the case may be, he may be closer than me. It just kind of depends on how the calls hit. We're learning more and more that it's not necessarily getting the RSI medic to the scene. It's more meeting them on the way. Where can I cut you off? You know, you're going to drive 10 minutes, not an hour to the trauma center without a more definitive approach. So,
right. And it's such a high risk skill.
Yeah. There's definitely a lot of risk involved in it. And, you know, that's why I said, you know, we limit our provider group kind of in a way just to hopefully get more reps for the people who are doing it. That way it's, you know, that exposure and experience definitely helps.
What are the most common complications with RSI? How do you mitigate those?
Yeah. So, and I couldn't quote our data. I couldn't tell you what the most common complications are from us specifically. We have a great quality assurance guy who could spit those numbers out for you, but I don't know them off the top of my head. You know, if you look, not even just, again, pre-hospitally, but if you look sort of throughout the healthcare continuum, your biggest concerns and complications are hypoxia and hypotension.
Right.
Most frequently, I think that there's always sort of a transient hypotension that comes with the procedure and just sort of mitigating and managing that.
What are you using for an induction agent?
Hit me with the hard question. So we don't want to limit our providers. Like Eric said, we do our best to try to give people the education, training, and equipment and supplies necessary to tailor their treatments to their patients. So we carry etomidate, we carry ketamine, we have sucks, we have rock for our paralytic agents, and we don't tell you which one you have to use. However you're most comfortable doing it. The research shows that it really, at least from an induction agent, from ketamine or etomidate, there isn't enough evidence in either direction to show use one over the other, at least as it relates to hypotension. There's other reasons to use stuff, but as far as avoiding complications, I don't think it really matters.
And you really need to reduce that cognitive overload when you're performing that procedure.
Yes.
So if you can add a level of comfort for the provider with the medication they're going to use, I think that helps out tremendously.
Huge.
Yeah.
Huge. There's enough going on. You know, we're never coming into a perfectly sterile or calm environment. So being able to, you know, hey, I usually use this, or do I need to go up or down? As opposed to, oh, well, which medication would be the best option in XYZ?
Right. So you're intercepting in most cases a unit. So you do have at least a few minutes to prepare mentally for the procedure. But still, you're responding through traffic to get there at the same time. Right. So how much time are you really being able to prepare? So reducing all of that cognitive overload prior to getting to the patient, I'm sure helps quite a bit.
Huge.
Yeah. And honestly, if you're a paramedic in the back with a critical patient, maybe you're hanging blood and you're going to do RSI, man, that's a lot.
Yeah.
That's a lot on one provider to do.
Yeah. That's why for us to do the RSI procedure, you actually have to have two paramedics present. So if Eric's on an ambulance, he can't, just willy-nilly do it by himself.
Yeah.
He's going to have to request another paramedic to come. Even if he's the RSI medic, he's going to have to request a paramedic to come intercept with him to do the procedure, partly to reduce that overload. When I teach it, you're there to manage the procedure. The other provider's there to manage the rest of the patient, just to kind of break up that workload.
Yeah. Plus, you're taking away their ability to breathe simply when you paralyze them, sedate them, but especially when you paralyze them. Man, if you don't get that tube, you got to have a second provider there just to make sure you get that.
Yeah, just to help you out, give you that extra set of hands.
Yeah. And there are alternative airways you could use if you miss it, but.
Yeah. And, they're doing a lot of great stuff, other parts of the country too. I couldn't quote, but there's one agency that they've gotten rid of the RSI paradigm and they've gone to RSA, where they're doing the drugs, they're doing the paralytic, but they're just dropping a supraglottic airway.
Yeah.
In an effort to just reduce that cognitive load and make it easier.
Right.
Man, I think one of the hurdles we have is not a huge hurdle. I'm not seeing it often, but we just have to remember to treat the patient. If they need an airway, that's great, but we still have to treat the patient and the underlying causes. You don't want to overlook that part. And a lot of people will get called for RSI and they're worried about the procedure where the patient still needs to be treated. We still need to give fluids, or like you were saying, blood, or which is equally as important. If we can manage the airway without the RSI initially, we can take the patient, improve their condition, and then do that procedure. So
that's such an important point too, huge. Right? Because it's so easy to zero in on a procedure and get so hyper-focused on that maybe you're not paying attention to some other things you should be.
Yeah.
Yeah.
Yep.
God. And having two providers there, it's got to help out tremendously.
Sure.
What are some of the complications you're seeing?
Most, and I hate saying this, but most RSI procedures that I've been involved in have been very smooth. You know, we have a really good program. We have these checks and balances, the two paramedics. We have pre-oxygenation is huge. Preached, like he said, hypoxia is one of the biggest things that could go wrong with it. So we have, a lot of checks and balances that they've enforced in us in pre-oxygenation and treating the patient. But I think one of the hurdles that we have is our distance to the hospital, because sometimes by the time we get to the patient, there's 5 minutes to the hospital, and you're really getting close to not wanting to do that procedure now, because you're not wanting to do it in the ambulance bay. You don't want to waste any more time delay going into the hospital for the definitive care. So I think proximity to the hospital can definitely be a challenge.
Yeah.
Yeah.
Well, and a lot of times in those cases too, the RSI paramedics, they're going through additional training. Every paramedic learns how to intubate. It's reteaching you. Of course, we have to teach a difficult airway, and we teach some other tips and tricks and stuff like that. But what we're really looking for from our RSI paramedics isn't to be able to intubate any better than anybody else. It's realistically like you're supposed to come as the voice of reason. You should be the expert in optimizing that patient in every capacity.
Awesome.
That way, hey, we're only 5 minutes from the hospital. I'm not even worried about the procedure. I'm going to optimize the patient so that as soon as they walk into the ER, everything's done. Like they don't have to worry about making sure the patient's sats are up or managing their hemodynamics, or, we can call the hospital and be like, hey, get your paralytics, get your stuff out. We're going to need an airway. We'll be there in 5. They'll be ready when you get there, and have that transition be smoother. The patient's already ready. But, the RSI paramedic definitely has additional training in that as compared to somebody else who may be in the field.
Yeah. Can you describe a call where RSI clearly saved the patient?
Oh, yeah. We got a couple of those.
Choose the best one.
Well, I have respiratory calls can get bad real quick. And I think we've all been to that CHF or COPD era where it waited to the last minute to call us. And no sooner do we step inside and they look at us and we get them on the stretcher, they code.
They crash.
Right? They crash. They code, and now it's CPR. You go into the hospital and they have very low poor outcomes with that. And, when they call 10 minutes before that happens and we get there and we recognize, okay, we need to secure this airway. We'll try CPAP. We'll try the steps leading to it, because the goal would be improve them without RSIing, of course. But we did have one. It was right after a code. A guy called. It was a CHF patient. As soon as we got him onto the stretcher real quick, we were getting ready to get him into the ambulance, CPAP. He coded on us, and, poor outcome with that. It was like 2 hours later. We had basically the same call. We get inside and he sits on the stretcher and he looks like he's about to arrest on us. And we were able to go ahead with the RSI procedure, give him some extra PEEP, and we got him to the hospital, and he was extubated and on the follow-up, and he made a great recovery. So I definitely see some huge benefits with it, especially acting pretty quickly.
Yeah. One of, outside of the medical patients, one of the great things, our local trauma center, a lot of times they call them victory laps or victory walks with their major trauma patients who get discharged, who reintegrate back into the community when they come for a follow-up appointment with surgery or ortho or whatever the case may be. They'll take them on like a tour, like, hey, this is where you started, then you went to this floor, then you went to rehab here, and then you essentially to give them a chance to, not even them, to give the people who cared for them a chance to see that what they're doing makes an impact. I think the hospital probably does it in the mindset from bringing some clarity and information to the patient, but we value that as providers, that opportunity to like, okay, what I'm doing matters and makes a difference. And I had one that there was a wreck with entrapment he was 16 or 17 years old at the time. And the wreck was bad enough that it essentially blew the bottom out of his vehicle. Like the floor was just gone.
Wow.
And, obviously in extremis when they initially got there, the beauty of working in a fire rescue agency is that these aren't, we're not coming as a third party or, a third service coming in and being like, oh, how do we integrate with the dude that's cutting on the car? We benefit from the fact that I was just eating dinner with him 20 minutes before this call went out. I know what he's going to do. I'm running the calls with the same people who have the same training and stuff that I do. The guys on the first arriving fire apparatus, I want to say they got him out in like 7 or 8 minutes. It was super quick. By the time I showed up, they had just transitioned him into the ambulance and he was in a bad way. And I was like, hey, I'd love to stay and do this while we're not moving down the road, but like, we got to go. There's more going on here than I can fix by myself. And we took off and we went in such a way that we ended up leaving the new guy just standing on the scene like, well, where am I supposed to go?
Where'd everybody go?
Yeah, but by all measures, I want to say his ISS was within the range, his injury severity score, the trauma data people do. By all measures, I think he should have been dead. And probably about a year later, I got invited to the victory lap for him. To get to meet him, get to meet his family. He's up walking, talking. He's still doing OT. He's still doing PT. He's still doing speech and working through the process, but he's reintegrated back as a member of the community, which I think is the ultimate goal.
Yeah. Yeah. You gave him a chance at a life.
Exactly. He was a 16 or 17-year-old kid. Just, if I remember correctly, he was driving home from Bible study.
Wow. And honestly, that's the reason why we do this, right?
Yeah.
To bring our knowledge, skills, and abilities to bear on a crisis situation and to have a positive outcome, because so many times there isn't a positive outcome.
Right.
Wow, that's fantastic. Hey, it's Jason Falvey. Thank you for spending part of your day with me here on In Service. If something from this episode hit home, maybe it reminded you of a call, a shift, or a hard lesson learned, follow the show and please send it to just one person and ask them to follow. Now let's get in service. Let's talk a little bit about ultrasound, because you can't even find numbers on the number of agencies that are actually deploying ultrasound in the field. It's such a unique specialty. And you guys not only do that, but you're doing blood and RSI as well. So that's really progressive. And what motivated your agency to deploy ultrasound?
So, I think anybody who follows any of the EMS stuff, be it podcasts or reads gems or anything like that, there's always an article or a podcast episode on ultrasound. It's definitely one of the hot topics in EMS to see where it can fit in. And that's kind of where we are with it, is how are we integrating it into our system? Similar to RSI, it's not something that is...
It's low frequency.
It's low frequency, but it's not something that everybody's doing either. And we have a core group of people who, we stole the term super user from XYZ tech company, but we have our ultrasound super users who we send them home with an ultrasound. Like, go home, scan your kids, scan your wife, grab your mom and them and put probes on people and get used to it, because it is a low frequency procedure and it's not without risk. And when I say risk, I don't necessarily mean direct risk. It's not intubating an esophagus or an infection from an IV. It's more of an indirect risk of what brain space is doing this tying up that could be used for something more important or more beneficial.
It's taking your attention away from potentially something else more serious.
Yeah.
Right.
Or we delaying care so we can do an ultrasound.
Right.
That's
to identify.
So we've done training on your typical fast, looking at the abdominal compartment and thoracic compartment and the pelvis for blood from trauma. We've done some training on sort of lung ultrasound for pneumothoraces or hemothoraces or whatever the case may be. Tube placement is another option for it. We're avoiding intentionally things like OB. We're not doing any ultrasound guided procedures for IVs and stuff. I've been lucky enough to get to do that when I work in my part-time role. And that's a quickly diminishing skill. That's a lot of fine motor. And if you're not doing that every day, or that's something you lose quickly.
Right. I would think with your call volume here, IVs is probably
probably
not an
IVs
issue
don't
for you
tend to
guys.
be an
Do
issue.
them all the time.
Yeah. We definitely, I would put our guys starting IVs against anybody else, especially the good old fashioned EJ. Yeah. So we're not doing any ultrasound guided procedures or anything. And we're still figuring out through the super users how to integrate it fully into our system. And we're still in sort of that initial
you're pioneering
play with it.
Yeah.
See how it fits into your workflows. I know Eric's one of our super users.
Yep. We use it for cardiac standstill
Yep.
and cardiac arrest, pseudo PEA. Should we be going a different route, or should we be looking harder for the H's and T's? If maybe we do have some movement, we'll still do CPR, but
Awesome.
what route are we going to go? Something I like it for as well is the presence of B lines, that we can see fluid in the lungs. Some of those harder patients to determine whether they're COPD exacerbation or a CHF exacerbation. Sometimes it can be difficult, especially if you're moving or it's a loud environment. Stethoscope only goes so far, so it can kind of eliminate unnecessary treatments. You feel confident going one route. But like Mike was saying, you don't want to delay care by doing the ultrasound. We do it doesn't replace a good assessment. It doesn't replace really evaluating your patient and being confident in that. But it has some
It gives
places for
it
sure.
gives you another tool situation,
sure.
right?
It definitely has utility, like Eric said, with B lines and stuff for differentiating your respiratory patients. We rolled ultrasound out, a week after I went out and bought a fancy sound canceling stethoscope because I'm old and I can't hear anymore. That's actually where I've found probably the most utility from it, especially those mixed picture patients where they have a history of both and you're, you're having a lot of trouble breathing, but I don't know which road to run down. It definitely helps give you confidence. We're an agency like a lot of others that are working the vast majority of our cardiac arrests on scene. So it's nice if we're calling for orders to terminate resuscitation or whatever the case may be, hey, I got a good look. There's no activity. There's nothing that looks like anything's moving, just to kind of fill out that picture. It's never one piece of the puzzle that makes that decision, but it definitely adds another avenue.
How do you pull that into the documentation on the patient?
So through our reporting software, ultrasound is actually a documentable flowchart item, but the data files are very large.
Yeah, I bet.
So we're actually using like a third-party data process to save them all.
Is it just putting like a snapshot in there?
Yeah, so
Snapshot image?
the ultrasounds that we're using have the ability to like record loops. As part of doing it, you're supposed to record a loop and upload it into that so that they can be reviewed later on. Just to not even necessarily for like a quality assurance, like a true quality assurance reason, but more of a, hey, like what are you guys seeing? Are you able to get a good view in this circumstance? The guy who's running the rollout is doing a pretty good job of trying to stay on top of all of it. We have a text group where it's like, oh, look at this ultrasound that I found. That's helping with the learning of seeing it. It's like anything else, getting reps in. If you're not running a bunch of calls that week, but you got 3 ultrasounds, it gives you something to look at, something to think about. Hey, maybe if you had tried to move your probe a different way, you might have got a different view or whatever the case may be.
Is it changing any clinical decisions you're making?
So that's one of the big things with this initial rollout is the ultrasound is a thing after the fact right now. We're not doing it until everything else is done. We don't want to use it at this point. For us, we're not using it enough, or we're not validated enough. We're not seeing enough, exposed to it enough to be able to say, hey, this should guide your treatment. The best example would be for something like a pneumothorax. We're not using that to make the decision of is this or is this not a tension pneumothorax.
Right.
If you think it might be a tension pneumothoracx, dart it.
Yeah.
Right. And there should be other clinical signs
right.
and symptoms.
Right. Right. We're not going to use that as the, oh, well, I didn't, or I think I saw lung sliding, so I didn't go ahead with the procedure. If the other clinical signs are fitting that this is what needs to be done, then it's what needs to be done, and we can.
But what Eric pointed out is sometimes you can't always hear very well in
Right.
these environments. So it would be a nice tool to have.
Absolutely.
To confirm what you're thinking.
Absolutely.
Sure.
Yeah.
Yeah, and that's where it has its utility, and like anything else, it's reps. It's how do you fit it in? How often are you doing it? Quality assurance on the back end, just trying to make sure that you're getting what you need to get.
Right.
Yeah, one of the harder parts about ultrasound is actually getting a good picture. I mean, it's not a simple place it here and you see. You really have to, everybody's a little different. You really have to maneuver it. And when doing so, you're getting a grayscale sort of okay picture.
Really grainy.
Real grainy.
Yeah.
And so, I try to use it as often as I can, but it's difficult. It's difficult to get a good picture of what you're looking for. And
Even our super users, where it's still a limited group, they're not doing it as much as they'd like to. Probably not doing it as much as they need to be proficient. So we're trying to figure out where the line is to see is this,
what niche is this fitting into?
Right. Because if it doesn't improve, regardless of the intervention or procedure or anything, if it doesn't improve patient care, is it worth doing it?
Right.
And I know you get some years of experience on me, but I think that it'll be similar to the 12 lead EKG. There's resistance. There's figuring out, do we need to do this? Is it worth it? Yada, yada, yada. And then you start talking about.
Now it's commonplace.
It's standard of care, but that's because it improves an outcome in the long term. By getting that EKG early, you can activate the cath lab. Patients who get the cath lab faster have better outcomes. I think long from now are the days where it's, we'll just do a fast. We're not going direct to an OR on an unstable patient with a positive fast. It's not there yet. It's not ready for prime time yet. It may be in certain agencies with certain providers, but across the board, I don't think it's there yet.
So will EMS eventually carry lab level diagnostics in the field?
Yeah. Eric, what's your thoughts? Like, where do you see it as the provider in the field? Is that?
I see a little bit more resistance with that. I think holding certain things. I mean, we're doing not so much labs, but we're drawing cultures for sepsis patients, and we're working towards maybe getting troponin or something like that. But I don't think we're going to get like a rainbow or any huge lab draws or anything like that. I don't see that anytime soon.
Maybe an initial, I think that you'll see a delay. Your critical care trucks and your interfacility transport stuff where they're dealing with these crazy complicated patients, they're already doing it. For the vast majority of your 911 community-based emergency response ambulances, I think that utility is, like Eric said, it doesn't make sense to do something if we're not going to do anything with the information. Information for the sake of it, getting information doesn't provide any benefit to patients in our setting.
Unless it's affecting care downstream.
Right. One thing, as technology improves for not even just us, but in hospital, we have these ultra high sensitivity, uber specific troponins for MIs and stuff. I don't even necessarily see it making a clinical impact on what we do or what the hospital does specifically or directly, but it with the troponin where it's drawn at 2 hours and 4 hours. So you have your initial 2 hour as a screening. If it doesn't go up in that 2 hours, those patients may be safe to discharge. I can see that having a role where we're grabbing an initial troponin that's 3 hours from onset. We get the initial. Next one comes at 2 hours, and that can be the decision point. That might help offload ERs or risk stratify patients to clean up the system of care as a whole, which may provide some benefit. Pre-hospitally, really the only thing that we're going to be managing super acutely would be like a crazy potassium or something in that dialysis patient. But there should be other clinical indications that would push treatment, not just that one value.
But your extended transport times in some areas of the county is there could be real value in that.
There could be, especially when you think something as simple as trauma care, not as simple as, but something as vague as trauma care. One of the treatments for patients with closed head injury and significantly increased ICP is like a hypertonic saline. The ability to grab a sodium level on that patient and see that they're not already at 155 or whatever the case may be to determine if that treatment may be safe and beneficial, that may be something that happens. I think it'll be time, not necessarily a big push.
What about AI?
AI, the topic of the century, I think, shaping a generation of children.
How is that going to influence clinical decision-making in EMS?
So we were just talking about ultrasound. And I think that where AI might shine is in that realm. We look out, our documentation already has an AI narrative built into it.
Right.
But Eric was saying patients are different. Probe position is different. What you're looking for is different based on the patient. Having AI built into those systems, not even necessarily to form the diagnosis of is or is not an issue, but to say, hey, a little tag over, this is the liver, or the screen turns green when you visualized XYZ structures. I think AI definitely has utility in that to help with that learning curve of proficiency.
And I know there are providers out there now using it to compound or analyze different signs and symptoms or to point them in different directions when it comes to vital signs.
Yeah. And, I think deck of cards, maybe house of cards. There's an AI EKG interpretation app now. Yeah, it's the Queen of Hearts EKG for occlusive MI. So it's using the evidence from the less STEMI and more occlusive versus not occlusive MI paradigm shift that cardiology is currently going through, and it uses the information from that to use AI to interpret your EKGs.
Wow.
Because
you really can't trust what you're seeing now at the top of that.
No.
At the top of that strip.
That man in the box is
it could be
not
this.
super reliable.
Yeah, that man in the box is not the best. So they used it on 18,000 EKGs, with 10,000 of those being like clinically validated outcomes, and then they tested it, and it achieved 90% accuracy and 81% sensitivity.
So you see a big role with the use of that.
I do.
Yeah.
I do. It's like I tell my kids, AI, and I work with my kids a lot on AI, just talking to them about it. You know, I think that the younger generation, as my kids' age, and realistically, like people entering college right now that grew up with it, they're looking at it as a replacement for learning and education. And I don't think that's the answer. I think that you have to, have the foundational understanding to know when AI may be sending you awry, but it's a good way to offload stuff that isn't A, super frequently used, or B, applicable. 36 years old, and I don't care when Napoleon invaded France. Like that's not a tidbit of information I use frequently. But if the question came up, I'd love to be able to turn to AI to go after it.
Right.
And I think that's where AI will have its heyday, is how we can integrate it using people to validate that and ensure that it's not being taken off the rails.
My oldest daughter is a coding and cybersecurity major.
Okay.
Graduates this year, and boy, she warns.
Yeah.
She has some very stark warnings
Yeah.
about AI and what's it going to do. And it'll probably replace coding, is what she's saying.
Yeah. My 12-year-old's trying to learn how to do a little home coding thing, like a little electronics thing. And
That's awesome.
I told him, I was like, you're not allowed to use AI until you get the foundational stuff.
Yeah.
You don't have to know every code. You don't have to know how to do everything, but know the foundations, understand the pattern of the language, and then you can mess with it.
Let's talk about the evolution of the paramedic from protocol follower to clinical decision maker.
I think everybody goes through that themselves. I mean, when you first start out, you're really following guidelines, protocols, not wanting to veer too much because you don't have the experience to go off of, and you haven't seen as much. And that translates. The more you work, the more you see, you start realizing, okay, last time this happened, or, and I think one of the bigger things to see is if your department supports that or not, with a, like I said, broad scope of protocols, allowing you to kind of, hey, this is a small guideline. This is kind of the general direction we want you to go, but they want us to make our own decisions. And I think that's really important. You have a safety net, but you really can get out there and do your own smart treatment.
But I think it's probably the biggest thing a new paramedic can do to reduce cognitive overload is have those protocols.
Yeah, absolutely.
Well memorized.
And it's the protocols are the bookends.
Right.
This is as far as you can go, and this is the rock bottom, and this is as far as you can go. How you dance in the middle is your discretion. Like Eric said, when you start off as a paramedic, the guideline for respiratory distress may include albuterol, Atrovent, Solumedrol, magnesium, CPAP, advanced airway management. Not every patient needs all of those things. And I think that the guideline and it's weird that just changing the name of what you call it can drastically shift your provider's mindset. You change it to a clinical guideline instead of a protocol. And now it's less about, did I check the box and follow the protocol? And it's more about, did I deliver the appropriate care to the appropriate patient under the right circumstance?
And really, experience is going to help guide that a little bit, right? If you've never seen somebody in respiratory distress, how do you determine how severe this is, other than the metrics they put?
Yeah. How fast are you going to progress through your treatment plan? Are you going to skip any of the early steps because you know where they're at?
So what separates the average provider from the exceptional provider?
Sweating.
Yeah, super user. Let's hear it.
Yeah, I think that's a tough question.
So And when we talk about, I'm going to specifically answer provider, not paramedic, not EMT, not looking at it from what makes an exceptional employee. Because I have great providers that are bad employees and great employees that might be bad providers. I think the thing that separates exceptional providers is they are committed to learning something from each encounter. They never forget that at the end of the day, they are caring for people, not just a patient, not just a number on a run sheet, but they're actually caring for people. And they take feedback. We were talking about it when we were doing some education the other day, that the mindset of a lot of providers is that it's hard to sometimes provide feedback because they feel that it's an attack on them, as opposed to a review of a decision or a counter argument to a thought process. I would say that the exceptional providers take feedback well, good and bad. They're committed to learning from every opportunity, and they don't forget that they are patients. You know, it's one thing to be able to come in, and Eric's not phenomenal because he can come in and intubate somebody upside down, sideways in a tree. Eric's phenomenal because he can do that while delivering compassionate, understanding care that will be remembered regardless of the outcome. And that's what separates them. It's not just a tacit knowledge thing or a skill ability. It is a human level compassion that I think.
And it's hard for providers, I think, because you're out on the road. You're often making these decisions, really important decisions, by yourself in the middle of the night. And then somebody comes along and challenges that decision. That can be hard.
Yeah, that's leadership challenge 101 for EMS supervision, is balancing that. It's important for leaders to stay engaged in what's going on in the field and try to get out and run calls with their people. That way that when they do have to have that conversation, it's not, you don't know what it's like up there in the ivory tower. I was knees deep in it too, and we both may have made a bad decision, but going back and reviewing it is important.
But if you can, as a provider, if you can stay open to feedback like that and realize that there's always going to be a better way. There's always some way that you can improve on what you're doing, whether it's your knowledge base, your skill base.
Yeah, 100%. And you know, it's hard that we don't. I can't think of an EMS agency in the country that provides the perfect amount of education and training and exposure that every provider is like, man, every day I go in, work teaches me something new. You know, my employer teaches me, or my service teaches me. You know, we're learning a lot from each other, and we're learning a lot through outside sources. It's hard. It's a challenge to try to stay on top of everything and find work-life balance and get enjoyment from other things in your life. But constantly seeking out that educational opportunity is important.
Yeah, I agree 100%. What mindset shift must occur to safely use advanced interventions like blood ultrasound, especially RSI, in my opinion? Super user.
I would say, you have to be open to new things. You know, there's two things most firemen and EMS hate, and that's change and the way it is, right? So having an open mindset to new.
And anything that challenges seniority.
Yeah, exactly. For sure. Being adaptive and accepting for anything new, like blood, it's still new for us, but accepting that it's going to benefit the patient. Yeah, it's going to be challenging and it could be scary. You kind of have to embrace it, and that mindset shift of accepting all of that, I just think is very important, and pretty much at all levels, at all levels of EMS.
And really, there are so many challenges in EMS, but when it comes to patient care, knowing when to, and you told a story earlier about, you're 5 minutes away from the hospital. Do you really want to be doing this procedure in the bay? Or is it more advantageous for the patient to expedite extrication into the ER? Yeah, it's really the challenge.
For sure.
You also have to have the mindset has to come from the notion that what we're doing may not directly impact the patient in this 10 seconds. We went to paramedic school and we spent all this time focused on the interventions that we do as paramedics, and reassess your intervention and identify improvements or worsening or whatever the case may be. but we're still only looking at a snapshot of that patient's care. A lot of these advanced interventions, not even just blood and ultrasound and RSI, but even stuff like antibiotics, we're not seeing the impact of that in the 20 minutes that we're with them.
Right.
But did I decrease the amount of time they have to spend in the hospital? Did I decrease their mortality? So taking that mindset shift away from what I'm doing now to make the situation better and saying what I'm doing now is going to improve the continuum of care for this patient's entire treatment course, I think definitely gets people more into the mindset of we should or should not.
So what leadership decisions enabled your system to expand their clinical capabilities? And that's right at you.
So I've been very blessed in that our executive leadership team is very open to new ideas and open to stretching it a little bit.
Forward thinking.
Definitely forward thinking. From a more ground level view, the leadership decisions that are being made, we have 3 sort of clinical and operational supervisors right now. We're getting ready to add 3 more to help split the workload. But as a whole, we've all come to agree that we need to decide to act aggressively and provide high quality care. Like that is the expectation for the people who work for us.
And you get in the providers, you at least have to have some providers that are willing to graft onto that.
Yeah. Yeah. And no matter what you look at, provider knowledge, skills, ability, average grades in a class, number of tourists in a vacation destination, it'll all fall under a bell curve, right? We can put a curve on everything. One decision is that we're not going to allow the lower performing of the providers to hinder the high performers. We're going to create guidelines that encompass both. Nobody's going to be allowed to be below our standard. Nobody's going to be allowed to fail to meet that expectation. But even within that, it'll shift the whole curve right. What was your 60% underneath the bell is now shifting further right as opposed to the other direction.
And there are providers that are probably going to get, I don't want to say left behind, but probably won't be able to keep pace with.
Right.
Yeah.
Right. And if you can't keep pace, we'll provide you every tool and opportunity and resource you need to stay on that pace. That's the responsibility of an organization. But over time, those providers will fall off. They'll either get on the ship or get off the ship. The bus is going, get on or get off.
We're heading in this direction.
Right.
We want you to come along.
Right. I think the decision that we're not going to, write everything to the lowest common denominator, but instead set the expectation for what we want it to be, I think definitely helps push that.
How do these now? Are you including providers in these discussions before implementing?
Yeah. So to an extent, we do all of our protocols by an open committee, like an ad hoc committee that involves medical training, quality assurance, the medical operations supervisors, and providers of all levels in the field. And they're all allowed to bring their questions, comments, concerns, and ideas. There's been stuff that's been brought up by providers that, we in the operations supervision side are like, hey, it's a great idea, but for whatever reason that you're unaware of, we can't do that yet, or we, have to back burner that. And it creates an opportunity for them to sort of have those discussions of like, oh, I heard this agency in rural Alaska was doing, open thoracotomies. Like yeah, that's great, but I don't think we're there yet. So not stifling their growth or the organization's growth, but looking at the other challenges. So it helps everybody. It helps us stay fresh and new and up with everything, and sometimes provides context for why certain things can't happen.
And I'm guessing skill decay probably doesn't play a major role in your operating theater, but it's still a factor. Right?
Yeah, it definitely is. And it does. We're running a bunch of calls. We have a bunch of units, but it's not a 1-for-1 system. We have some units that are running more than 12 calls a shift. We have some units that may only run 1 or 2. So skill decay is definitely something we have to be aware of and concerned of. That's why stuff like RSI is kept limited. That way, theoretically and hopefully, they'll get more exposure to it. And it's hard. getting people into environments where they can practice skills in a safe environment is only getting more challenging. I remember when I was coming up as a paramedic, a lot of your high performance EMS agencies had open access to ORs and, all this other stuff for things like airway management.
Oh, yeah.
That's getting more and more challenging. Nearly impossible these days to get agreements between the number of residency programs and doctors not wanting to take on the liability and people speaking in legalese that boggles my mind. It creates challenges for that.
I know when I came, before I hit the field, I did over 40 OR intubations. They don't do that anymore.
No, I was well over 20. And, that was when I moved down here and I started getting students, they had already sort of lost the ability to hit the ORs.
Yeah.
And, the first paramedic student I had was like, oh man, I'm going to intubate a real person. I was like, what? Now I'm in an education role and I'm having to, how do I navigate this? You can only do so much with high fidelity simulation. And huge proponent of it, huge fan of it, has 110% of place, especially in continued competency and initial education. But nothing will replace the reaction and the sensation of live tissue on a patient.
Just how do you simulate the pressure of dropping that tube in those critical moments, in those high stress environments?
Duct taping an airway head upside down under a table is not the way to do it.
Right. Yeah. I just attended a training event where that was the scenario.
Yeah. That's not the way to do it. I think we're better off utilizing other ways to increase the stress level. Intubation physically, the movements and stuff associated with it aren't overly complicated. But when you get in there and look, it's processing the visual information and what else is going on and making that sort of mental model of how to do it. That's where the challenge comes. Not even factoring in the did we, do we, should we, not even figuring that in, just, once you first go in.
The physical move.
The physical movements, it's that combination of sensory information and stuff that we need to find a way to replicate. But if we can't replicate it, we have to figure out a way to make stress an accepted factor.
Yeah, I remember going when I went through my RSI class, and we were, it was mainly during the testing, but even practicing, something Mike would do would jack up the radio super loud. And so while we're in there having that radio blasting and trying to figure everything out, and things were placed not really where they should have been, adds a little bit more stress to you. So it's not the same, but it definitely helped replicate some higher stress rather than just intubating a dummy.
Yeah, trying to... What is it? The term stress inoculation?
Stress inoculation.
Yeah.
And we teach about that in the RSI class for that reason. There's a great book, Colonel Grossman, he wrote On Combat. It's a book, he's a psychologist, and he talks about how your physiologic response to like stress, how it impairs your cognitive thought processes. Phenomenal book. I'd recommend it to anybody. You learn more about why you make mistakes and why you can end up in a rabbit hole more from that book than I did anything else in life.
Yeah. And the loss of fine motor skills.
Yeah, heart rate's above 140, you start to lose those fine motor skills. It's real hard to start an IV on a 1-year-old when you're 10. You add in the caffeine and nicotine that's fueling the EMS systems in this country.
Yeah, absolutely.
Could mix paint.
So what is EMS getting wrong right now? Ooh. We're looking at you.
I mean,
I'm a boss. I think everything's fine, remember?
I'd say one thing that's, kind of a trend that's not so hot right now is burnout, and not recognizing a lot of people. I mean, we talked about high stress and lack of sleep and a lot of these other things that it's pretty easy to get burnout and running what we see and what we're running.
If I just add this in, we talk about the high stress calls, right? And you run a series of those that can burn you out. But burnout can also occur from running. And honestly, 80% of the calls typical EMS agencies run don't really require an ambulance or a paramedic to be on scene. And yet if you run 10 of those in a shift and then you drop in that 1-year-old pediatric arrest that will burn a person out too.
Mm-hmm.
Yeah.
There's no downtime to recover from that, from the 10%.
Yeah. Yeah, and I think some support. I think what I've seen is a little bit better support for people in the last few years, but I don't think it's at the degree where it should be. Recognizing and really helping out with that aspect. So I think, as far as people go, I think that's a big one.
Yeah, honestly, when I got into it in the early 90s, it wasn't even a consideration. Walk it off.
You weren't allowed to have any feelings.
You took a big hit, you walk it off.
Yeah, well, especially, I was lucky the guys who trained me were super experienced by the time I got to them. And, these were guys who lived through the initial waves of the AIDS and HIV epidemic and all that. Like, they'd be covered in blood head to toe and just standing there smoking a cigarette. And like, there was no, that was the expectation of sort of mental resilience that was modeled for me, was just dudes who had been through it, and they're okay, they're fine. But one thing that I think that we're missing, EMS as a whole, I feel deeply, I can't prove it, but I feel deeply that it relates to Eric's point. What we're getting wrong is recruitment and initial education. We are recruiting and building agencies and providing initial education under the paradigm of emergency medical technician or emergency paramedic or emergency whatever. We're throwing emergency and public safety and all this other stuff into the initial sort of foundational framework for new providers. When, like you said, that's not 85% of our job. So we're creating a false expectation and a false sense, as opposed to saying, hey, we are a healthcare section that provides care to people who are typically underserved, who are lacking access to other resources. And I think that if we were to make that shift in the initial education and create a better perspective for new providers coming in, instead of, we're going to teach you how to work 17 cardiac arrests backwards, upside down, and sideways.
Which is all important.
Which, and I'm not saying we should slack off on that education. Yeah. What I'm saying is that we need to start educating from a healthcare mindset and a public service mindset for our providers, instead of just public safety and emergency response.
When do you think it's going to split off, right? Because we're standing in two worlds. We're straddling a fence here of being first responders, public safety, and healthcare practitioners, right?
Yeah.
Is it going to split off? Is it going to shift at some point?
I don't know.
Because the likelihood in just looking at what Eric's doing out in the field right now as a medic with RSI, ultrasound, blood, and all the skills and knowledge and ability he carries, is that going to be the expectation we put on everybody?
Right. So
that's on an engine or...
Definitely not overnight. That's not going to be an overnight thing. It's not going to be...
Is it realistic to have the level of competency that you're operating at?
I don't...
Can we expect that from every single person that...
No, I don't think that level can be expected from everybody. I do think that we'll see a higher expectation from everybody. I don't know if it'll be to that level. The other issue you run into is, once that becomes the expectation for everybody, your Erics and your other high performance providers and systems throughout the world will get bored, and they'll need to find something else new to do to challenge them. So there's always, I think, going to be that sort of split. As far as the split from public safety to healthcare goes, I'd like to think that it will shift more towards the healthcare side of things. I don't think we can get out of the public safety pool, because no different than law enforcement and the fire department are a safety net for XYZ issues, hazards, problems in the world. There's always going to need to be a safety net for healthcare. And the ability of paramedics and EMTs to straddle that balance is what will set us apart in healthcare. So I think we'll always be straddling, and I don't think you'll see a shift all the way to one side or the other.
Yeah, I agree. I mean, for sure. I think you hit the nail on the head there. EMS
is such a safety net. That's the beauty of our job. We don't we're not worried if you can pay. We're not worried about any of that stuff. It's what is the problem? How can we help? But I think that as much as we need to train and educate and provide tutelage for handling those emergencies, we need to set the foundation that that's not who we are.
Yeah. What makes you optimistic about the future?
You know, I'm on the tail end of my EMS career. I'm transitioning to a full healthcare side. I am most optimistic about the generation immediately following me and the generations coming in now. They have a better sense of who they are as people. You know, when I started this as an 18-year-old kid, I didn't know who I was, what I believed in, where I was. I think that the younger generation has a better sense of who they are, and they're members of the community. So they're coming in and able to kind of bridge gaps within the community that we weren't. They're smarter than we are. They're coming in used to the ideas of technology and using the resources to learn that I had, but I didn't know necessarily at the time, early on in my career, how to use them effectively. They're coming in having already been through, they probably had 2 years of education that was fully computer-based. You know, I didn't have that. So I think there's definitely opportunities for them to learn more, interact more, and make more of an impact on the people that they serve than maybe we had.
Yeah, I'm pretty optimistic about it. Seeing what I've seen in the last, say, 10 years, every ambulance has the opportunity to do so much more. Like we were saying, we have blood, we have more RSI capabilities, we have a vent on every ambulance, antibiotics.
Go ahead.
Every ambulance we comes ready to bear.
Yeah.
Vents, pumps.
Ultrasound. We've seen a lot of technological growth, and I think I've seen a lot of paramedics keeping up with that, or EMS in general keeping up with those expectations, and I think it's been great. You know, I see a lot of driven paramedics and progressive, aggressive, and I see that more so than I see people not wanting to do stuff and not wanting to learn. So I'm pretty optimistic about it. I think it's a good thing.
Yeah. And I hate to go back to me about this, but Eric brought it up earlier, where we're more aware of the impact that this job can have on us. You know, one of the biggest issues that I think EMS has experienced in its history is it's not a job that people tend to do very long. You know, you have your lifers and stuff like that, but it always tended to be a stepping stone for different professions. And there were people who just got out who, you know, I can't do this anymore. I'm not going to do something else, but I can't do this. I think that an awareness and an openness to start to have those conversations about burnout, about mental health. You didn't talk about that stuff when I started. You'd say, oh, I'm getting burnt out. That would be it. That would be the end of the conversation. It wouldn't be, all right, hey, let's move you to a slower spot for a couple weeks. Hey, why don't you just take a week off? Why don't we worry about some mental health stuff? So I think I'm optimistic that we're going to be able to capture providers for a longer period of time so that we don't lose out on the experience that they can provide. And I think the willingness to have those conversations about burnout and mental health will help that.
I agree. Thank you guys for being here today. You are both a credit to your communities you serve. You're out, you're doing some incredible things here, and it's definitely pushing EMS forward to where I think it should be, and definitely the direction it's headed in. So thank you guys.
Thank you.
Appreciate you.
Yeah.
Thank you for listening to In Service, the EMS Podcast, where frontline experience meets leadership insight. If you have found value in this conversation, please like, subscribe, share, and leave a comment. You will find links in the episode notes.